right, so Poiseuille's law takes this a little bit further, right? And so what Poiseuille's law says is that the change in pressure P multiplied by the radius to the fourth power, the radius of the vessel, the tube, okay, times pi, 3.14, right, times the N, this funky N here stands for viscosity. It tells us how thick a liquid is. You know the expression, blood is thicker than water? It is, right? There's more in blood than there is in water. L stands for the length of the vessel, and then this 8 you don't have to worry about. They derive that from calculus, so we're not doing a calculus form of any of this. That's not the point of this. All right, so it's a constant. And then they manipulated this equation to give you the resistance equation, which is essentially a manipulation of this. You could actually do the same thing, it wouldn't be that hard. But so this is the more complicated. And then there's something called compliance. Compliance is how, the best way to describe this is how stretchy a vessel is. How easily you can expand something is the compliance. You can almost think about the compliance as the opposite of resistance. Compliance is how easy I can stretch. So if I was looking at a rubber band that is easier to stretch has a higher compliance than a rubber band that is more difficult to stretch. The resistance is how difficult it is to do something, if you think of it in terms, right? So if I have a rubber band that is very easy to stretch, its compliance is high, but its resistance is low. Yeah, questions?
So when they say rates, are you still something with the L that are the same?
Yes, this is a big L. Yeah, this is the same L. That's correct. Yeah, good question. So if something is very compliant, it's easy to stretch it, its resistance is very low. That means that the recoil effect is going to be low because there's a direct relationship between resistance and recoil. The harder it is in a rubber band sense to pull something apart, or the easier it is in this case, the less it will recoil, right? Because if it's easy to pull it apart, when you let go, is it going to snap very hard? No. Okay, now let's take another rubber band. When you take a rubber band that has a really low compliance, it's not very stretchy, but if you're strong enough and you muscle the thing open, how much snap is that thing going to have? A lot. That means that the recoil effect is super high. So resistance and the recoil are in a 1-to-1 ratio, right? As one goes up, so does the other. Compliance is sort of the opposite end of the coin. This is going to become super important when we get to the respiratory system. I will be here. Dr. Miller's going to go through this. And when we talk about different types of diseases like asthma, emphysema, chronic bronchitis, right? COPD, which chronic bronchitis and emphysema fall under, and your understanding of compliance and resistance are super, super important. So we're going to start talking about them here with the fluids, but then when we go to the gases, it's equally as important. Okay, and then you've got heart rate times stroke volume, equals the CO stands for cardiac output. So, getting back to compliance. Compliance is the change in the volume over the change in the pressure. If you have a huge pressure change and a small volume change, right, then the compliance is low. Probably the resistance is super high. If you have a huge volume change for a small change in pressure, then the compliance is high, the resistance is probably low. There's something called mean arterial pressure, and you can find it a couple of different ways. You can find it using cardiac output, and TPR stands for total peripheral resistance. It's the entire resistance of the system, the periphery on the outside. Total peripheral resistance. Or you could calculate it, and this is an easier equation to sort of wrap your mind around. You need to know both. This is more theoretical. This one you could actually calculate. You take your diastolic pressure, multiply it by 2/3, and add it to 1/3 of what's called systolic. So what do I mean by diastolic and systolic? So it is universally accepted that when we take blood pressure, right, with a blood pressure cuff, we're looking for something like 120/80, right? And the top number is called the systolic pressure. And the bottom number is called the diastolic pressure. Systolic is always on top, diastolic is always on the bottom. Systolic is always, in your case, higher than diastolic. Now, we'll talk about 120/80, how it's not normal blood pressure anymore. We used to think it was, it's not. It's good, but it's not great. All right. So when we think of blood pressure, you think of this. But in terms of physiology, in terms of your overall blood pressure, you can then take this, right, and you can say, well, I can multiply my diastolic number, and this is in millimeters of mercury. Millimeters of mercury, because that's how we measure it, and add it to 1/3 of the systolic, which is 120 millimeters of mercury. Okay? And you're going to get something like, I don't know, without doing the math, something between 90 and 95 millimeters of mercury as your mean arterial pressure. Something like that, give or take. Okay? So that's the mean of these two. And the reason that if you're multiplying this one versus this one by 2/3 and 1/3 is because your heart, right? Systole is the active compression of your heart. It's when your heart is physically pumping. Okay? Diastole is when your heart is filling, when it is resting. And your heart spends 2/3 or 66% of the time resting, and 1/3 or 33% of the time actively pumping. And that's why you get those numbers. They're not magic. You spend most of your time at rest with your heart. Okay? So that's where they came up with those numbers. But again, this is the calculation I would make you do. This other one here is more of a understanding the system type of question. So that equation would help you answer a theoretical type question. It wouldn't be necessarily a calculation. Although with any equation, you could always do a calculation. Right? I'm not generally interested in just having to do calculations for the sake of calculations. There has to be a big reason. These help you understand the system. They're tools. So memorize them. These are kind of like the memorizing the intracellular and extracellular concentrations. You got to keep them in your head. You got to know them like that, because we're going to talk about stuff, and you can always relate the entire system back to these equations, and then those graphs that I gave you, the Wigger's diagram of the TV with this. If you're armed with all of these equations and those two graphs, there's really no question I can ask you that you can't answer. Yeah. Oh yeah, sorry about that. That's right. Ejection fraction. So the ejection fraction is actually a clinical term. So if you go into an internal medicine doctor, a cardiologist, right? Usually you start talking. If a doctor is talking with you about ejection fraction, you probably have a heart problem. For most of us, it's a non-issue. Right, we're normal, and so we don't go. Has anybody ever gone to doctors? Anybody have a heart issue here? If you don't, you probably never even heard of this term, because it only comes up when you start dealing with patients, usually that have had a heart attack, that have congestive heart failure, that have some kind of other disease. So it's the stroke volume, and we're going to talk about what stroke volume is, over the end diastolic volume. And we're back to all of these throughout. We're going to do examples of the PV loop figures. We're going to talk about these terms. So it is, the ejection fraction gives you an indication of how strong the heart is. It tells you basically how much of the blood that it can pump out it is actually pumping out. And when that number gets really, really low, for instance, when it gets into the 20s, that 20% is really, really bad. That you have a really, really weak heart, something is bad going on. You're swelling up with water, you can't walk around anymore, you walk and you're tired and you're huffing and puffing, right? That's what a congestive heart failure patient is like. All right. Good. Thank you for reminding me about that. All right, so let's move on. Any questions on that? So these you just got to memorize starting today. So cardiac output equals heart rate times stroke volume. Cardiac output is another measure of how strong your heart is. Right? The ejection fraction is one way of doing it. Cardiac output. You take your heart rate, and if you know what your stroke volume is, and there are ways to figure this out, you then know what your cardiac output is. This is, in addition to, you could actually calculate this, this also is a theoretical. In other words, knowing this equation and how the three of these relate to one another helps you answer other types of questions about the system. Okay? So understanding the relationship. So if I ask you a question about stroke volume, you know this equation, you've memorized it, right? And even if it doesn't have a lot of numbers, it might not. I might not actually be asking you for a calculation. I might be asking you something about how a change in the stroke volume would have an effect on cardiac output or heart rate. And if you understand the relationship, right, you could algebraically solve for this stroke volume, get cardiac output and heart rate on the other side of the equation, and say, well, here's some possibilities. One could go up, one could go down. And so even with just having that one equation, you could give a pretty detailed answer as a possibility. Just that, right? A very sophisticated answer. All right. So heart is a pump. Okay. The heart uses what's called a pressure head. Okay, and we'll talk about what that is, a pressure head. So the heart is a pump that moves the blood. Its activity is expressed as cardiac output in reference to the amount of blood used per unit time. So there's a time component here, right? This is in stroke volume is usually measured in milliliters or liters, and heart rate is beats per minute. So there's a time component. How many mils or liters do you move per unit of time? Per second, per minute, per hour? Again, a small fraction of cardiac muscle cells called autorhythmic cells determine heart rate. That's the pacemaker. The SA node, the sinoatrial node, is the pacemaker. They are autorhythmic cells. How is this similar? To make you think here. Didn't have a question of the day. We learned about cells in muscle that used to be able to contract but can no longer contract. These cells in the heart are very similar in that they started off as being contractile cells, but now they're rhythm generators, they're pacemakers. What types of cells in skeletal muscle sort of had that same evolution? Think about skeletal muscle and what we learned. The different parts. And which parts once could contract but no longer can and now have a different function. Now have a different function. Do all muscle cells, skeletal muscle cells, are they all able to contract? The answer is no. Not all of them can. Which ones can't? The intrafusal muscle fibers. Only the extrafusal can. The muscle spindle used to be a contractile unit. It no longer is. What's the function of the muscle spindle? What's the function of the muscle spindle?
To monitor stretching.
Stretching. That's right. It monitors mainly stretching, but it also does force, right? These autorhythmic cells started the same way. They were sort of like the extrafusal fibers. They could contract. They got converted over time into these autorhythmic cells. So they no longer contract, but they generate an electrical pulse. They generate a current on their own. So within your heart is the control center. If I take your heart out and I place it on this table, it will continue to contract. Because it does not have to be connected to your nervous system to do this, because it has its own autorhythmic cell. It has its own built-in pacemaker. It's called the SA node, or the sinoatrial node. So if your heart is beating at 60 beats per minute right now, it's because your SA node is roughly set at 60 beats per minute. The more fit you become, the lower your heart rate goes, the slower the SA node will conduct a pulse. That's actually a good thing, right? Because that assumes that the heart is actually getting stronger. You can actually have the opposite occur. Your heart could be getting weaker and the SA node could be firing less often. So there's a situation where the answer is complicated, right? Just having a slow heart rhythm doesn't mean you're actually a stud, right? It just means that your heart rhythm is slow. You could be, or it could be that you have some kind of condition. And so both can occur. All right. Most of 99%, so 99% of the cells can contract. They're contractile. No big deal. All right, let's get to the important stuff here. We just talked about this. So this is what I was talking about with the arterial pressure, the autonomic. Okay, so the autonomic system. Remember, the autonomic system is made up of the sympathetic and the parasympathetic. Sympathetic, and we know the ganglion, right? We know that picture. It was a question on your exam. Got to keep that in mind. It's going to become important because we're going to keep using it. Dynamically adjust cardiac output. So even though the pacemaker sets the rhythm, your peripheral nervous system and your central nervous system, the autonomic nervous system, the sympathetic and the parasympathetic, can adjust your heart rate. If you get very, very angry, what happens to the ability of your heart to contract and your heart rate? Go up or down. That's your autonomic nervous system sending messages to the pacemaker to speed up. So you can adjust it. What happens if you get really, really mellow and relaxed? What happens to your heart rate? Goes down. That's the parasympathetic limb of the autonomic nervous system sending signals to the pacemaker to slow it down. Do you need that for these things to occur? No. And then we're going to get into why you can still have that happen. Because if that was true, if you needed the connections, they're wires. You think about them as the nerves that go in there. Then somebody who has a heart transplant would not be able to respond to exercise. When they got angry, their heart rate wouldn't change. And when they got mellow, their heart rate wouldn't change. But that's not true. Think about that for a second. You can cut the wires, and they may never grow back. You can cut the nerves, right? And yet they still respond normally to anger and fear and exercise and relaxation. So how does that happen? How does the body actually do that? You do it. We'll talk about it. Okay. Blood composition and hemostasis are described. We're not going to talk too much about blood composition. You do it in Physio X. It will show up on your exam, but as it relates directly to Physio X. So we're going to skip those portions. But we're going to talk a little bit about this. This is just a hematocrit, right? Hematocrit is the number of red blood cells, the erythrocytes here. What's in white here is called the Buffy coat. It's the leukocytes, the white blood cells, and platelets. And the rest of your blood is made up of plasma, which is water, basically. So we're going to talk about what hematocrit means. On average, it's 45%. For females, the normal range of hematocrit is from 35 to 45%. And for males, the normal range of hematocrit is from 45 to 55%. So the viscosity, that N, that weird N in that equation, for men have thicker blood than females. It is a fact. It is one of the reasons why men are at a higher risk for strokes and heart attacks than females are, because we physically have thicker blood than females. It gives us an advantage because that thicker blood is caused by having more red blood cells. Red blood cells carry oxygen. The more oxygen you carry, the more aerobically fit you can be. So on average, an average male against an average female is going to be more capable of doing activity. Now, that's on average. Look, every person in the world, an average, right? But clearly, that's not always true. But on average, that's true. That's one of the adaptations. Okay. All right, so you should know, we're going to talk about the circulation and the different parts of the heart. Right, there are two ways to look at the heart and circulation. So you can look at it in terms of there's an arterial side of your circulation and then there's a venous side. The arterial side takes blood away from the heart. The venous side brings blood. Venous is included the arterial side, right? The venous side takes blood back to your heart. That's one way to think about the circulatory system. The other way to think about the circulatory system is to say, well, there's a systemic circulation, meaning the whole body, and then there's a pulmonary circulation, which means that you go from the heart to the lungs and back to the heart. So really there's four ways to think about it. So there's two divisions. Two ways to divide up the circulatory system. Venous versus arterial, systemic versus pulmonary. Systemic meaning the whole body, pulmonary meaning only going through the lungs, arterial meaning stuff that goes away from the heart, venous meaning stuff that goes towards the heart. So those you need to know. Does that make sense to everybody? That's something you probably learned before. You may already know that. So hopefully. But if not, let me know. This is something else you should know. You should have a pretty good idea of the percentages, at least for the percentages, not the numbers. I'll give you that. I'll concede the numbers, but you should have a pretty good idea of what percentages each of these organs gets of your circulation. And if you take a look at it, the majority of your blood, and this is at rest, so right now, the way you are right now, 24% of your blood goes to your abdominal organs, right? Your liver, your pancreas, your kidneys, your adrenal glands, your GI system, your stomach, your intestines, right? Abdominal. 20% goes to your kidney. We're going to talk about, that's the very last topic we do is renal. We talk about the kidney. Okay, and why something that is only 2 to 4% of your body mass gets 20% of your circulation. It's a disproportionate amount of blood for something that's not very big at all. And then 20% goes to skeletal muscle and 13% goes to your brain. Your skeletal muscle, even at rest, takes up a fifth of your circulation right now. You're not doing anything. 20% of your blood has to go to your muscles. That's a lot too, but that makes sense, right? The majority of your body mass is your skeletal muscle. So that one makes sense, 20%, right? The kidney, like 2%, 2-3% of your body mass is getting the same amount of blood. Think about that for a second. That's a huge disconnect. Your skin usually gets about 9%, your brain about 13%, and then you have other. Right? Now, these are the control. These are sitting here right now resting values. When you start to exercise, these will change. And we'll look at that chart. I don't think it's really on here, but there's another version of this that has the exercise values, and you'll see that they change dramatically. When you start doing physical activity, you start moving around, these numbers have to change. Okay? Okay, so your body has the ability to redistribute its blood where it needs it the most when you need it. All right, a little bit of fluid dynamics. Continue on with fluid dynamics. All right, so you have two artery vessels. We're going to talk to them as arteries. We're going to talk about this one. Okay, in the top vessel, you have a pressure point. P stands for pressure. P1, and you have P2. The blood is flowing from left to right in both cases, from 1 to 2. Okay. The point here is 100 millimeters of mercury, because that's how we measure blood pressure, in millimeters of mercury. When we get to the respiratory system, we actually measure breathing pressure in terms of centimeters of water. It's a convention. You can do it either way, right? It's just the way the early scientists started measuring this stuff. A sphygmomanometer has water pressure in it. It's measured in millimeters of mercury. You can easily do the same thing with centimeters of water. Okay. So P1. So this point here is 100 millimeters of mercury. Downstream, at this point here, you have 10 millimeters of mercury. Okay? So this is a difference of 90 millimeters of mercury. What is this very similar to in terms of what we talked a lot about before the first exam? I sounded like a broken record. When I had asked you a question, it's the most common answer that I wanted. We were talking about what? The most common answer you could have given me for the first exam, and probably gotten part of an answer right. It usually involved what? The electrochemical gradient. That's right. I ask it a lot. This is a pressure gradient. So there's lots of gradients, right? If you take geography and earth science courses, right? If you take geography and earth science courses, you talk about pressure gradients all the time, right? High pressure, low pressure. We talk about gradients with heat. There's a heat source and there's a heat sink, right? You always go from high to low. This is the same thing. Your body doesn't defy the laws of physics. We work the same way. The planet works the same way. So this is not an electrochemical gradient. This is a pressure gradient. So when you do the math, you can see that the pressure gradient in this vessel is 90 millimeters of mercury. So the flow rate is 10 mils per minute. Okay. Then we go to the second one. We look at it. The second one has a pressure here of 500 millimeters of mercury. This is physiologically possible, by the way. This is physiologically possible. And these numbers here are mean arterial pressures. This is not systolic or diastolic. These are mean arterial pressures. Okay. So we took whatever these two were and we fused them, and that's the number we're getting. All right. So in this one, you have 500 millimeters of mercury here, and you subtract. At this point, is 410. What's the pressure gradient? Lo and behold, it's the same. So what does that tell you? That the flow rates are identical. Are the systems identical? So let's just read the statement at the bottom. Though the pressure is higher in the lower tube, the flow rates in the paired tubes is identical because both have the same pressure difference between points 1 and 2. Now, are the systems exactly the same? No. I mean, you would not want to have a mean arterial blood pressure for longer than a few seconds of 500. The highest mean arterial blood pressure ever measured was they put a flow probe catheter into an Olympic heavyweight lifter. And they measured his blood pressure during the clean and jerk. And it is the highest blood pressure ever measured. It's something like 675 over 385. So this is physiologically possible for a few seconds. If you had a blood pressure like this for an hour, you'd probably be dead. Like your system would blow up. It would explode. but for a couple of seconds, you could withstand these pressures, right? But that's the highest. Normally, we're looking at 120. We're looking at 90, right? And we'll look at what hypertension does, right? Because this is real. We'll look at some real numbers for hypertension, and then compare that to these and see where it compares. So this difference here is sometimes called a pressure head. Sometimes called a pressure head. How many of you have been in Nicaragua? Okay. On the finger? We all went to the finger. Okay, you're young enough that you know vaporize at all. Okay. So in Nicaragua, those of you who haven't been there, they have to, on this farm that they own, they have to have these water towers. We have them too, but they're a lot bigger in the United States, right? But on the farm, there are 3 water towers. There's one behind the house, right? So there's one behind the house, and it looks something like this, and it's on the stilts. And it's got these tubes coming out of it, right? And then way down at the back of the property, there behind one of the cabañas, on the left side, doesn't mean anything to you if you haven't been there, are these other ones. And there's 2 of them. They look something like this. They're water towers, and they got pipes coming down. Okay? None of you would have been there with me, because I haven't been there in a couple of years, but yeah, none of you would have been there with me. Except for Alex. Alex went with me. Okay. So one is low, I don't know, it's like 10 feet off the ground. This one's like 20 feet off the ground. Something 20, 25 feet. Okay? Why do they put these on the property? Because they need water pressure. They need water. So just having a tank on the ground will give you water. Would the water flow? No, it wouldn't. You need pressure. How do you think you get, if you measure the water pressure in the taps here, so if you turn not this one, because these are great to be higher pressure, but coming out of your parents' house or in the dorm somewhere, you've got 30, 40 pounds, and it's measured in pounds of pressure coming out, 20 pounds of pressure, something like that. Where did that pressure come from? Did you ever think about that for a second? Where did the water pressure come from? Why does water flow out of your faucet? I mean, we don't think about it, do we? But if you stop for a moment, why would water flow out of the tap? Do we have pumps on campus? Do you see any water towers on this campus? Are there? Does Carthage have a water tower? Does it have a pumping system? So where's the water pressure? Just magic? It was born there? The pipes. They put the pipes up, they put the water in it, and then somebody snapped their fingers and magic, right? No. You actually have water towers for different areas, depending on where the source of the water is, right? Assuming that it's coming from uphill. And if there isn't enough water pressure, almost every town has one of these, right? And you know them, because you've seen them on the side of the highway, water towers, and they've got, Bedford, Illinois, New Berlin, Wisconsin. And some of them are taller than others, and some of them are bigger than others, right? That's what's generating your water pressure. For every foot, every 2 feet that you go up, you created 1 pound of water pressure. So if the thing is 80 feet high, you've now created 40 pounds of water pressure. Now, depending on where the water source, sometimes you need more of these depending on how big the community is, right? Why are you talking about water towers? Because your heart does the same thing. Your heart is the pressure head. The pump generates the pressure difference. And the reason that your blood flows is not because the heart is pumping. It's because the heart has created a huge pressure difference between the left side of it and the right side of it. So if you go back to here, the pressure coming out of here is about 100 millimeters of mercury. This is the uphill side. This is the gradient. But the pressure coming into here is almost 0. So that's roughly 90, depending on where this is, 90 to 100 millimeters of mercury. That's the difference. why the blood moves. Not because the heart is physically pumping. Now, it is in a sense because the pump creates the difference. Right? The pump creates the difference, but to explain the pressure difference, I like the water tower example because here there is no pump. You're just using gravity to feed it. Your heart, the left side of your heart, is essentially like an elevated water tower. That's what it is. That's what it does. And so if I ask you on an exam, why does blood flow from the left side to the right side, and why does it flow at all? It is because of the difference between point A and point B. It's because a pressure head was created by the left side of the heart, in this case the left ventricle. And that's why in physics term, that's why the blood actually flows, not because the heart is actually pumping. The pressure difference is a consequence of the pumping, but that's not why it's flowing. Technically, it's the pressure difference. Okay. Does everybody understand this? And the fact that the numbers are high or low, it always comes down to the pressure difference. Now, again, this is very, very dangerous. You don't want to be in this area, right? Not a human being. There are other animals on the planet that have pressures like this, and it's fine and fake. We're just not designed for it long term. Okay. This information, again, whether you've memorized it or not, I'm going to talk about this. So if it's been a while since you've taken anatomy, if you've never taken it, if these terms are new, you should know these terms. This is part of the language. If you've done this recently, then just review it. But when I talk about plasma or capillaries or ventricles, and we're going to get to it, you should know what I'm talking about. The assumption is you know what I'm talking about. So read this over. It's pretty basic stuff. But you may not know what an arteriole is. Some people don't know the difference between a capillary, an arteriole, and a venule. You should know that. It's important. So you have to know some basic anatomy. Okay. So these parts here, you should know this too. This is another diagram you have to know. You just have to know the blood flow through the heart, the structure of the heart. You got to know the pieces. This is something you can easily start memorizing. It may just be rememorizing, just refamiliarizing yourself with it. Okay? But you should know the route that the blood takes, and that's what this shows you. I'll take you through it quick. Don't write this down. It's going to be way too fast. Okay? It's all outlined in the PowerPoint. Just follow along with me. Right? Blood, this is the superior and the inferior vena cava, the two largest veins in your body. They're physically the largest blood vessel in your body. Okay? They are bigger than the aorta. Veins are generally larger than the same category artery. And there's a reason for that. So the largest vessel in the body is the vena cava. The largest vein in the body is the vena cava. So blood that's coming back to the heart comes into the vena cava, comes into the right upper chamber of the heart. It's called the right atrium. It flows through a valve here, right, called the tricuspid valve. And you got to know what these chordae tendineae are and these flaps, which is an atrioventricular valve. From there, it flows into the right ventricle. The right ventricle then pumps, and it flows through the pulmonary valve. This is the pulmonary arch. And the blood then goes to your lungs. It circulates through the lungs. It becomes reoxygenated. It comes back. So this is the pulmonary artery. When I talk about why that's a weird statement to make, it's an exception to a rule. This is the pulmonary artery. Okay? And then it goes to the lung, and then the blood comes back from the lungs in the pulmonary veins. It comes back to the right atrium, the left atrium, excuse me. The left atrium pumps the blood through the bicuspid valve or the mitral valve. It's the same thing. Into the left ventricle, and the left ventricle then pumps the blood out through the aortic valve into the aorta and essentially everywhere. And then it goes to arteries, large arteries, small arteries, medium arteries, small arteries, arterioles, capillaries, venules, medium veins, larger veins, vena cava comes back, and blood gets distributed. So you should know that, right? And in advanced bio phys class, that should be like, gotta know that like that, right? That shouldn't be something that you're thinking, wow, that's a hard question. It's not a hard question, right? You gotta understand it. So start memorizing this because it's a requisite. You have to have it. And if there's something you don't understand, then we can talk about it. But most of it's pretty self-explanatory. We are going to talk about like oxygenated and deoxygenated, those types of things. Okay, so here, it's all in here for you, right? That's why you have to write it down. It's already in your notes. It's done. So look at the picture. I think the picture and this go together very nicely. It's all very self-explanatory. Something you just got to know it. Like that. Okay. So let me talk about a couple of things here. The caveats. The blood that comes back to the heart is deoxygenated, which means it has less oxygen than when it started off. Because the blood that comes out of the aorta is oxygenated. It's got about as much oxygen in it as it can carry. Okay? But by the time it gets back here, it's in blue, and in the veins, these cells, right? The cells have been eating. When the blood cells combine in the capillaries, there's a diffusion, right? There's a gradient of nutrients going into the cells, oxygen going into the cells, and then the cells give off CO2 and garbage, and that stuff diffuses back in. Right? So by the time the blood gets here, it's lost a good percentage of its oxygen. So it's deoxygenated. That's why it looks blue. It actually looks purple. It's not actually blue. As a rule, an artery is a blood vessel that takes blood away from the heart. As a rule, a vein is a blood vessel that brings blood towards the heart. Now, why do people get confused that this thing here that's in blue is the pulmonary artery and this thing here that is in red is the pulmonary vein? Because they use the wrong definition of an artery and a vein. The one that's people that are not in the know use is that, well, there's less oxygen in the veins. So that's what makes a vein. That is generally true. There is generally in most veins less oxygen than an artery. So they should all look blue or purple. The pulmonary artery still looks blue or purple. That is because an artery is technically a vessel that is taking blood away from the heart. When this goes from the right ventricle to the lungs, is the blood not in fact going away from the heart? That is why it is called an artery, not a vein. Even though it is the only artery in the body that carries deoxygenated blood. That's why it looks purple. Now, the reverse is true for the pulmonary vein. Right? Most arteries carry oxygenated blood, right? So the veins don't carry oxygenated blood. But a vein, by definition, is a vessel that takes blood back to the heart. In fact, you're going from the lungs to the left atrium. Isn't that coming back to the heart? So the fact that it's carrying oxygenated blood is sort of, so it makes no difference. So that's why people get confused with them. If you just look at the picture, if you just look at the color, you're going to screw this up. If you took anatomy last semester, right, and Dr. Miller asked you what's this vessel, and you said pulmonary vein because it looked blue, well, you screwed it up because you didn't use the right definition, right? Now, I'm not going to ask you that here, but you need to know the difference and the true definition. The majority of the time, veins carry deoxygenated blood, and the majority of the time, arteries carry oxygenated blood, but that is not 100% of the time true. There are exceptions to every rule. This is an exception. Okay. Questions? going through a lot of this quickly, but a lot of this is hopefully, you've heard this before, it's basic stuff. All right. The electrical conduction system of the heart. So once you've memorized all of this, you don't have it memorized yet, but you will, right? We're looking at that. This is actually a picture, a cutout of the muscle, the actual physical muscle of the heart. Okay? Muscle of the heart. Now, in the excitation contraction coupling sheet, you actually have the sequence of events on how this thing will contract. Okay. So, the electrical conduction system starts with this. In this top part here, in the top right-hand corner or so of your heart, in the right atrium, there is something called the sinoatrial node. It's called the SA node. That's the pacemaker. Remember that a pacemaker is made up of cells, right, that generate what kinds of potentials? Graded potentials that ultimately turn into action potentials, right? There's these, and so the sinoatrial node is a pacemaker cell. We're going to talk about how that actually occurs. So your heart rhythm, the beat, this is the on switch. So if you know someone who has heart problems, someone who's older, who has an artificial pacemaker, what they actually have is something that replaces this area here. Remember, these are non-contractile autorhythmic cells. And so when somebody has an artificial pacemaker put in, the doctor, surgeon has to go in there and ablate. They basically obliterate this thing. They burn it. Because if they don't, the actual, your inherent pacemaker will compete against the mechanical, electrical one that's just been put in. You can't have that happen. That'll kill you. So in order to do this, you've got to get rid of the one that's semi-functioning. It's gone forever. Never going to come back. But now you have an artificial pacemaker. It's usually implanted in the chest. Okay. So the sinoatrial node will cause an action potential to occur. That action potential will spread electrical current everywhere. Okay? That it will spread everywhere. It'll go into the chambers here, okay, and it will go to this point eventually. Now, what's important to note here is that where these valves are, this area across here, it's called the A as in Adam, V as in Vanessa, junction. This is called an AV junction. And this AV junction is insulated. So you can think about this as a sheet of insulation that separates the two atria, the top chambers, from the two bottom chambers. Okay? It is insulated. That's really, really important. Because when the electrical current spreads, except for this one special spot here, this area is pretty much insulated, with this being the most insulation. This isn't completely insulated, right? So all of this goes out, and these two chambers contract simultaneously. Right? These two contract at the same time. The fact that the AV junction here is insulated is a time delay mechanism. It is a time delay mechanism. Why do we need a time delay mechanism? Think practically how the heart works. You've got four chambers, you've got two atria, you've got two ventricles. Why do we need a delay from the time these two contract to the time these two contract? Practically speaking, why do you have to delay the signal? How does the heart work? Yeah, go ahead. Because the blood that got pumped here is going into the ventricles, and you got to fill them first. If these contract before the blood comes in, if they contract simultaneously, what blood are you going to pump out to your body? Zero, or very little. That's not good, right? That would be like a fibrillation type thing. That happens all the time. People die from certain types of fibrillations. You don't want that to happen. So there's a sequence of events. You need a time delay mechanism. Part of that time delay is you make a really small spot that can conduct electrical current. It's tiny. And it's located right here. And it is called the AV node, or the atrioventricular node. I think I'll leave it there. I'm going to come back and start here next time. Because I've thrown a lot at you. Okay? A lot at you. So, three most important things. On the first day, usually the first couple of days, there's a lot of stuff that's you got to know stuff. So I'm okay with those types of important things. Are you going to raise your hand? Go ahead.
Know the part is how it works.
How it works. Very good. Lots of stuff to know. What else?
Memorize the equations.
Memorize equations. What else? We can do more than 3 today. There's a lot of stuff to know. What else? Yeah.
The distribution of blood.
The distribution of blood. How it gets the circuit. Right? Anything else? Yeah.
You're saying that pressure gradient is made.
Yeah. How is this pressure gradient made? And then it's the gradient that drives it. Yeah.
The pulmonary vein or artery.
Pulmonary vein. That's a tricky one, but if you know it, it's not so tricky anymore. Have a fantastic weekend. Awesome.